From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, and welcome to our listeners around the world. I'm Dr. Kristin Walter, Deputy Editor at JAMA, and I'm joined today by Dr. John Kirkwood, who is the co-director of the Melanoma and Skin Cancer Program at the University of Pittsburgh and UPMC Hillman Cancer Center. Today, we will be discussing a study that he co-authored with Drs. Joshi and Kashani Sabet titled Cutaneous Melanoma, a Review. This article was published online in JAMA on August 25th. Dr. Kirkwood, thank you so much for joining us on this podcast.
A pleasure to join you, Kristin.
Can you start out by mentioning what percentage of melanoma is due to cutaneous melanoma versus other less common forms?
So 95% of the melanoma that we in Pittsburgh, and I think clinicians across the country and the globe, see in Northern Europe and certainly across North America is cutaneous melanoma. The other variants are a few percent and comprise basically uveal melanoma, melanoma of the eye, mucosal melanoma, melanoma of the oral, genital, mucosal surfaces that are distinct from the cutaneous melanoma burden.
And how common is cutaneous melanoma in the U.S., and has the diagnosis been increasing or decreasing recently?
So the incidence of cutaneous melanoma has risen inexorably for generations across the U.S. The rise has been unabated over the past decade and threatens to continue straight through 2040. Currently, the distribution has melanoma fourth or fifth among men and women of solid tumors. The projection by 2040 is that it will be second. So this is a hitherto often thought to be rare cancer that really is one that none of us can afford to be ignorant of in daily practice of any sort in the US and in Europe.
And can you describe the characteristic skin findings of cutaneous melanoma?
So the findings that are characteristic of melanoma are a pigmented lesion, our use of the word lesion, but mole in general for people in the community, that is different from the other moles that we have. We're all born without any moles. We all have an average of 15 or 16 by the time we are post-pubescent. And then after 50s, 60s, we generally lose our moles. But there are people who have more than the usual number. So the pigmented lesions that we observe in those populations are part of the risk that we see for a cutaneous melanoma.
So specifically with cutaneous melanoma, what are the skin findings that you're most concerned about or that raise the flag for cutaneous melanoma?
So a pigmented lesion in the skin that is new, that is unusual, or that is changing are the typical hallmarks of a potential cutaneous melanoma. Having said that, it's obvious that we need to know what the skin findings were before the visit in which the patient presents. And that, of course, is part of the problem because there are few of us who have photographic documentation done from 6 or 12 months earlier to be able to say if something has changed. But a patient or a family member who notes a change in a pigmented lesion is often the heralding sign that brings the patient to a family practitioner, a primary care physician, a dermatologist, and then promotes the biopsy diagnosis that establishes melanoma.
And your article describes the most common subtypes of cutaneous melanoma. Can you describe these subtypes and their frequency?
So-called superficial spreading type of melanoma, the type that begins with radial spread, is about 70% of what we see. A kind of melanoma that occurs in the skin that is chronically sun-exposed, generally in the older populations, is called lentigo maligna melanoma or chronic sun-damaged melanoma, and that may amount to 15% of the melanoma burden. About 5% is nodular, rapidly evolving, and not in that either superficial spreading rubric or the chronic sun-damaged lentigo maligna subtype. And that is the general distribution for the commonest three types that we see.
And your article also describes modifiable and acquired risk factors for cutaneous melanoma. Can you describe the risk of melanoma associated with some of these important factors, such as a history of sunburns, tanning bed use, and immunosuppression?
The largest modifiable risk factor that we recognize for melanoma is recreational ultraviolet solar radiation exposure or indoor radiation, UV radiation exposure, indoor tanning, so to speak. And these significantly elevate the risk of cutaneous melanoma, and it is intermittent UV exposure, not typically chronic sun exposure. So the farmers and the fishermen who are out all day don't typically find themselves at increased risk in the way that folks who wind up going for beach vacations or other sunny spots where they get a bad burn. But blistering sunburns, sun sensitivity manifest in a tendency, for instance, to freckle, are all signs that the particular individual is at greater risk from UV exposure. And UV is the biggest risk we encounter.
Your article also describes heritable risk factors, such as having lighter skin pigmentation that burns easily, red or blonde hair, light eye pigmentation, and having a first-degree relative with a history of melanoma. Can you discuss the risk with lighter versus darker skin pigmentation and what percentage of melanoma is hereditary?
Yeah, so the risk of lighter skin pigmentation is that which we were just speaking about, UV sensitivity, burnability, and so forth. The darker skin complexions, African American, Asian populations, have a singularly lower UV risk profile and, in fact, have a different distribution of melanoma subtype risks as well, and are more often subject to what we call an acral type of melanoma that may happen beneath the nail beds on the plantar and the palmar surfaces of the skin, and are not thought to be related to UV exposure at all. But the types of melanoma that we see vary by the skin pigmentation and the racial derivation of the given patient. And these are things that we factor into our examination for patients every day.
And what percent of melanoma would you say is hereditary?
So we think that up to 10% of melanoma can be heredity-driven or hereditary. Those patients who have a first-degree relative or more than one first-degree relative with a history of melanoma have this particular predisposition. The gene known as P16 or CDKN2A is associated with that risk and can be a basis for genetic counseling and for follow-up that differs for people who have this predisposition to melanoma from the general population.
Another risk factor for melanoma is the presence of dysplastic nevi, also known as atypical moles. Can you describe their appearance and what is the likelihood of dysplastic nevi progressing to melanoma?
Yeah, dysplastic nevi are a remarkable entity that amazingly we discovered and first published in 1985, studying patients in Australia where about 1/3 of those patients who had had a melanoma had these unusual nevi. And what defined an atypical nevus, which we defined clinically, and then a dysplastic nevus, which we define under the microscope pathologically, is a difference from the ambient moles of the individual. They are, in general, larger, darker, more variegated in appearance. They may change over time, which conventional nevi generally do not. And we recognize that the presence of even one atypical nevus conferred an increased risk of melanoma in the population. The risks of melanoma that are associated with total nevi go up with numbers, and in people who have more than 100 nevi, the risk can be 7-fold higher than they are in the general population. For dysplastic nevi, as I said before, even a single dysplastic or atypical nevus confers some increased concern for melanoma, and the more, the greater that risk.
And moving on to screening for melanoma, can you discuss the current recommendations about screening?
The U.S. Preventive Services Task Force has deemed the evidence insufficient to warrant the across-the-board recommendation for annual skin examinations, even though these may only take a few minutes for practitioners in the community to do. But we recognize that patients who have either increased numbers of nevi or the presence of these atypical or dysplastic nevi, or who have a family history or a prior personal history of melanoma have an increased risk of subsequent melanoma. And for these individuals, we think the evidence is certainly adequate to warrant surveillance skin examination on a regular basis, ideally with a dermatologist. But it's also just fine, as we showed in Pittsburgh, if primary care practitioners learn the nature of these atypical nevi and the signs of melanoma, they can screen patients perfectly adequately for melanoma visually in their annual examinations.
Your article also describes how melanoma can progress from a non-invasive or in situ stage to invasive disease. Can you discuss in situ melanoma and how commonly these in situ lesions progress to invasive melanoma?
So melanoma in situ is a misnomer in a sense because it's called melanoma, so the patient thinks that this is invasive melanoma, but the qualifier in situ means that it is pre-invasive and therefore not formally an invasive cancer. So I think it's important to note that we have 100,000 new invasive melanomas a year in the US, and this is the risk that is rising with each year that we've documented now for a couple of generations. The risk of in situ melanoma is twice as high as that of cutaneous invasive melanoma. That is to say, another 107,000 people per year who will have in situ melanoma found in their skin. And these are not invasive cancers. We are honestly not sure whether they were destined to become an invasive melanoma or are stalled in some fashion in progression toward melanoma. And the actual risk of invasive melanoma is low in these patients. We think that if they've had resection of a melanoma in situ lesion, this doesn't require sentinel node mapping. This doesn't require larger surgeries of 1 centimeter or 2 centimeters, such as commonly required for invasive melanomas. And simple excision with even 5 millimeters of skin around it suffice for managing melanoma in situ.
When should patients with suspected melanoma be referred to a dermatologist, and how is the diagnosis made?
So a pigmented lesion that is suspicious to the practitioner of melanoma can be diagnosed effectively by the primary care physician by simple excisional biopsy or punch biopsy in the office. And so this happens in many primary care offices surrounding us here in Pittsburgh, and I'm sure across the country is true. A patient who is manifesting a lesion that is concerning to the practitioner who isn't comfortable to do a biopsy should be sent to a dermatologist or other specialist who can do biopsy for establishment of the nature of that lesion, because histopathology is the gold standard, the only standard for diagnosis of melanoma.
And can you discuss the percentage of patients in the U.S. who have localized disease, defined as only involving the primary site, versus nodal and distant metastases at the time of diagnosis?
Staging is pretty simple in melanoma, and stages 1 and 2 are localized. Stage 3 is lymph node involvement or regional spread, and stage 4 is distant spread. Presentation of a patient in the localized form of disease is 70% of what we see across the board. So the vast majority of patients that we see with melanoma have localized disease, which does not even involve the regional lymph nodes. A little bit less than 10% will have lymph node involvement, and a little less than 5% will have distant, that is to say, bloodborne or hematogenous disease, say to the lung or to bones or to other distant organs.
And what is the recommended treatment of localized melanoma?
So localized melanoma, I think, is best managed by local surgical removal. The local surgical removal by general surgeon, a surgical oncologist, or a dermatologist are all perfectly acceptable. The thicker the melanoma is in its invasion, and the breakpoint for concern is about 0.8 of a millimeter. That is to say, the thickness of the mechanical pencil lead that we used to use. And basically, 0.8 millimeters is amazingly thin, but at that threshold is where the risk for lymph node involvement rises to about 10%, and where we begin to recommend doing mapping of the drainage from the cutaneous site of the lesion so we know which lymph node group traffic would have happened toward. And it's amazing that it's really only since the late 90s that we knew how to map the drainage from a given site of melanoma. Because before that, if you had a melanoma, say on the right arm, all of the axillary lymph nodes would have been taken. And the same way in the right upper quadrant of the chest, the right axilla would have been just anatomically selected as the site to harvest all of the lymph nodes. With sentinel node mapping, we have both a more sensitive, a more specific, a more precise, if you will, approach, which when we map the drainage allows the surgeon to take one, not 20 or 30 lymph nodes, and to do a better job in diagnosing the presence or absence of lymph node involvement. Obviously, to the patient with lymph node assessment, the confidence with which we can establish that the node is truly negative is the most important criterion. We call this the true negativity rate. And in a sentinel node biopsy negative patient done by a capable sentinel node surgeon, it is 90 to 95% assured that the patient will not thereafter have any manifestation of lymph node involvement in the rest of their life. So that's a hugely powerful predictive tool. And so sentinel node mapping, we do routinely for patients over 0.8 millimeters in Breslow thickness. And again, the distant disease is seen in under 5%, typically when distant disease is manifest through hematogenous blood-borne dissemination. It's often the lungs in which we see a spot and need to make a pathology diagnosis by transthoracic needle aspiration biopsy or by removing the lesion. But the distant disease is the smaller part of the burden that we have to face. The larger part, happily, is this group with localized disease for which we don't think anything else is needed.
And what is the recommended treatment for patients with resected stages 2B to 2C melanoma?
Yes, this has changed amazingly 25, 30 years ago, to be honest. Treatment of patients with stage 2B, that is to say, deep primary disease at risk of recurrence, and that risk a quarter or a third of patients at risk of recurrence, was already being treated with old immunotherapy that isn't any longer pursued, beginning with the advent of checkpoint blockade immunotherapy, so-called anti-PD-1 therapies, pembrolizumab and nivolumab. This all changed 7 years ago, and those trials led to the treatment of patients with lymph node disease on a routine basis, stage 3, for instance, who all were treated after the 2017 era with anti-PD-1 immunotherapy to great benefit. More recently, 2021, we had the first trial positive for the same anti-PD-1 immunotherapy in deep primary lymph node negative patients, the 2B, 2C patients, and the benefit was very similar, a 40% reduction in relapses. And we now have a second anti-PD-1 nivolumab that was approved in 2023 with similar benefit of even 40-50% reduction in relapses. Those trials are recent enough that we don't have survival data yet to buttress the relapse-free interval benefit, but we expect that will come with time.
And what is first-line treatment for patients with unresectable or metastatic melanoma?
This truly has transformed in the past 15 years with the advent of what we call targeted therapy, BRAF inhibitors to be specific, and of checkpoint blockade, which began in 2011. We began using these to treat patients with unresectable distant metastatic melanoma. The benefit of the targeted therapy turns out to be transient in the treatment of distant metastatic disease, but the benefit of double checkpoint blockade, what is called CTLA-4 blockade with a drug called ipilimumab and nivolumab, were shown to have the ability to reduce relapse risk by highly significant margins. And now, at 10 years of follow-up from those trials that we started back in the early teens, we now know that survival for patients who were all destined for relapse and death only 14, 15 years ago, 40% of them are alive and well after the double checkpoint blockade for metastatic melanoma. So this is truly a revolution that we couldn't have anticipated even 15, 20 years ago.
Before closing, is there anything else that you'd like to mention that we haven't previously discussed?
No, I think this is really an area that we have seen remarkable change. And I think the change is seen at all levels of the disease. The advanced metastatic surgically unresectable disease that we just spoke about, where patients who all were destined for death and we had no effective therapies, now where the hope that we can actually cure this disease is perhaps the most radical change. The adjuvant treatment, which we did back in the 90s and until 2017 with older immunotherapies, with a benefit which amounted to 1/4 reduction in relapse, but 100% of severe toxicities are now replaced with treatments that have a 40 or 50% reduction in relapse and have 15 to 20% toxicity rates, severe grade 3 or higher toxicities, which we think is well balanced against the huge benefits that we see from these treatments in the adjuvant sphere given after surgery for patients who would otherwise likely have relapsed. The area that we really haven't talked about and where we're now focusing is the area of prevention, of early detection and prevention. And I think that truly will be a chapter for another day, but it's an area where there are trials for the first time to be initiated this fall across the National Clinical Trials Networks, and where we hope within several years to be able to point to things that allow us to treat patients to prevent melanoma development.
Thank you so much for sharing your thoughts with us about this interesting and very important topic. I'm Dr. Kristin Walter, and I've been speaking with Dr. John Kirkwood from the University of Pittsburgh and UPMC Hillman Cancer Center. You can find a link to the manuscript in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Shelley Steffens at the JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.